Welcome to the Home Healthcare Today show. I am your host, Dr. Cleamon Moorer. Our focus is alcohol awareness. Now, I know it's May, and April is designated as Alcohol Awareness Month. However, we understand that May, there's a lot of celebrations. There's graduations. We just came off Mother's Day last week. Father's Day is in June. A lot of wedding anniversaries, parties, and celebrations. And yeah, people tend to drink just a little bit more whenever they celebrate during holidays and as the weather changes. All right, but a serious stat related to alcohol, nearly 178,000 Americans die every year from excessive alcohol use. That's roughly 488 deaths a day, according to the CDC. Alcohol use disorder now affects close to 30 million people who actually admit having a problem with alcohol in the US. And since the pandemic, deaths from alcohol have climbed faster than deaths from any other substance. As we said earlier, April is Alcohol Awareness Month, but now that we're in May, I have the honor of connecting with today's guest, who is on the front lines of this crisis, literally driving treatment to the people who need it the most. Jordana Latozis, NP, is an acute nurse practitioner and the founder of Recovery Mobile Clinic, which is a Michigan-based nonprofit that she launched in February of 2020, just weeks before the world shut down due to the pandemic. After starting her career in the ICU and working through pain management, hospice, and primary care, Jordana saw firsthand how transportation, stigma, and broken systems were keeping people from getting addiction treatment. So she did something about it. She partnered with her husband, who happened to sell RVs this time of the year, right? Converted a recreational vehicle into a rolling clinic and started meeting patients where they actually are. Shelters, recovery houses, parole offices, and churches. 6 years later, the clinic serves over 40 weekly site partners across Michigan, has delivered hundreds of months of sobriety through Vivitrol injections, and Jordana has been honored with the AANP State Award for Excellence and named a top 100 healthcare visionary. She's here today to talk about the alcohol crises hiding in plain sight. Jordana, welcome to the Home Healthcare Today show.
Thanks for having me.
Jordana, let's really get into this. As we think about the crises as well as your mission, let's start with your story. The ICU department, you moved through pain management, hospice, primary care. When and what was the moment that pulled you toward addiction, medicine specifically?
Well, I come from a family of alcoholics, actually.
Okay.
So as we kind of really briefly discussed before the cameras were rolling, I don't really suffer from addiction from alcohol. And I was always questioning why. Why am I a little bit different? I'm a workaholic. That's debatable. But so that always interested me. And when I was working in the ICU, we'd see people who drank to an excess, right? Landing them in an ICU bed. As the development of my career took off and I went into graduate school and became a nurse practitioner, my very first job in 2010 was an interventional pain management clinic. And that was when OxyContin wasn't addictive and, chronic pain, the whole thing, right? So I saw that trajectory of that opiate crisis. And it rolled into my structure as a primary care provider that was providing Suboxone and Vivitrol for opiate and alcohol addiction. And that's when I really started recognizing the gaps and the socioeconomic overlap and some of the damage that was really done through the opiate crisis and just in generalized addiction, right?
Absolutely.
So the turning point actually came after I lost a patient. She was 23 and struggled with an opiate use disorder and couldn't keep her appointments at the clinic because of transportation in
Yep.
Oakland County, which is a pretty affluent area.
Absolutely.
But there was no access to public transportation.
Yes.
And she lost her battle. She overdosed and died at 23
Sad.
years old.
Yeah.
And she got there after like the sad history of, an injury when she was 15 as a track star, right? Just every parent's nightmare.
Sure.
So I went home and told my husband, this really shouldn't happen in the U.S. in 2019 at the time.
Yep.
Why is this happening? And he kind of mentioned it as a joke. He's like, you should put a clinic in an RV and drive it around.
Uh-huh.
And I
can sell you one,
Right.
Yep.
So that trajectory really kind of grew the mission because we knew we had to do more, right?
Yeah.
Medicine has to be more responsive to the patients that are struggling.
Yeah.
And that's not just with individuals with opiate use disorder, that's stimulant use disorder, and the most common, which is alcohol use disorder.
Yeah,
So-
that's incredible. Incredible. So the mission, derived like from family, understanding that, hey, there's folks in my family that are suffering from alcohol addiction. I'm not one. What's going on? What's deeper? And then the science and the medicine of you actually working in the ICU and being around folks. And then condolences to the loss of a client, at such a young age who unfortunately did not have the access to care. Jordana, let's fast forward or rewind and then we'll fast forward. 2020, started the pandemic. You're like, hey, I'm doing this 6 years later. But at the start of the pandemic, a lot of clinics scaled back. You've grown and scaled. What did that first year teach you? Part one of my question. Part two, what did it teach you about some of the folks that were getting left behind in the healthcare system?
Well, as we all know, COVID was very unique, right? I do attribute COVID to actually catapulting the clinic forward because, as you're very familiar, mobile clinics were extremely new back then. So trying to get an insurance company to credential you at that point probably wouldn't have happened without the pandemic, to be honest, because they were so desperate to have providers out there providing services, right?
Yeah.
So from that aspect, it actually helped us. But really, again, from my mission of bringing care to individuals who are struggling, we were going to homeless shelters at that time, and you couldn't get into a homeless shelter without a COVID test. Well, the COVID test costs a couple $100. They're not going to be able to. So we had to start doing COVID testing so we could just get individuals into homeless shelters and start offering them the medical treatment for addiction at that point in time. And then that turned into its own thing. But when you're moving into a municipality or a city and you're saying, I'm going to bring this mobile medical clinic into your area, the response was very, I'm so glad you're doing what you're doing, but go do it somewhere else. We don't have that problem here, right? So when you were able to address an immediate need that they had, which at that time was the COVID test, the story changed.
Definitely.
Now all of a sudden I was the solution, not, I joke, the Pied Piper bringing the problem with me, right?
Exactly, right.
So we learned from that.
Definitely.
We lead with a lot of primary care and mental health gaps. And then, oh, by the way, it's the same population, right?
Absolutely.
We're still seeing the individuals that are struggling with opiate use, alcohol use, and stimulant use disorders. So we're not as scary. We're an immediate response to a solution. And we've taken that model and really run with it because what we've actually discovered over the last 6 years is there's so many other holes in healthcare that people don't suffer from one thing. We're a system, right?
Absolutely.
So, we've expanded our services into psychiatric care, primary care, STD care, telemedicine care, because again, whenever there's a hole, we're like, there's a way that we can utilize this in the mobile model, and we've been able to grow the clinic from that aspect.
It's brilliant, Jordana. Congratulations on not only identifying the gaps, but then looking at how to build a cross-section of correlated services to begin closing those gaps for folks. I love it. Jordana, opioid crisis, we know it made a lot of news, a lot of noise, and there was great interventions to try to address it. But alcohol was kind of silently behind the scenes, rising up more. How is it that alcohol abuse has sort of outpaced the abuse of opioids over the last several years?
Well, it's socially accepted.
Facts.
Alcohol use disorder is one of the it's very bizarre. It's a very bizarre condition because it's actually one of the only conditions where we look at each other oddly when you're not using it. Why aren't you drinking? Are you pregnant?
That's it.
You know, what's
right.
going on? And so we actually
True.
push each other into having one more. You can have another
shot.
one.
Come
It's
on.
all good.
No, I deserve it. Come on.
Exactly.
Yep.
Right. It's a celebration. Why are you being so, what stick in the mud, whatever. It's a very weird cultural shift.
It's a round on me. Come on. We celebrate.
Yes.
We don't celebrate with apple juice.
Which means it's everywhere. No. You don't walk into the grocery store usually and see a line of cocaine, but you will see usually, but you will see, a line of wine bottles that really takes up for the whole side of the store, right? Totally. So it's it's in their face all the time, and it's really hard to kind of overlap some of that cultural stuff. Yeah. Now, during COVID, especially, we saw alcohol sales go through the roof, and we heard it all the time, right? Yeah. We joked about it. My gosh, my kids are they're raised by alcoholics. Mama's drinking wine in the middle of the day. Everybody's working at home. I actually had a friend who was an interviewing manager. Yeah. She had somebody pick up a beer in the middle of the interview.
Real talk. No way.
And she was like, it got so unbelievably culturally swung during that time that now we're still coming back.
But they were interviewing for like a bartender position.
No.
Oh.
She's a healthcare provider.
That's a problem.
Yeah.
Big time.
And she was, any interview, she's like, are you serious? Did you just pick up a beer in the middle of the interview?
Right. Cheers.
Like that's,
not cool.
But again, there was a lot of skew during that time. And there was the U.S. struggled with alcohol even before that. And some of these stats that we see with alcohol deaths are also tied into auto accidents and, those kind of things. But alcohol is also one of the least recognized addiction pathways too. So a lot of individuals do actually struggle with addiction, but don't recognize it in themselves or in their family members because we just binge drink on the weekends. Facts. Right? I mean, to the point where we black out, but I don't have a problem with it.
Exactly.
Right? So there's a lot of different opinions and ways to skew that. So that's why alcohol sometimes doesn't get reported the same way.
I get it. Jordana, you covered some myths, right? Tied to it. We got one more question prior to a commercial here. A lot of people think that alcohol abuse is a willpower issue, that I need to just be stronger, I need to do differently, I need to do better. I may have seen a loved one that overindulged, but I'm not going to be that way. I'm a better person. And many don't view it as a medical issue once a person becomes addicted to alcohol. How do you explain the disease model to a patient versus their willpower? How do we explain that to a worried family member who's never heard it framed that way, that it's a medical condition?
Any person struggling with addiction is struggling with a portion in their brain that is giving them an internal alarm system and telling them to drink or to use, right? Yep. What I tell people to really think about is, I want you to give up sugar for one day or coffee for one day and tell me how easy that was or how you felt. Sure. And that's without that internal alarm bell system going off inside their brain. Definitely. Right? Addiction is highly tied to emotional regulation, and it actually is a coping mechanism. So we have to not only outsmart the physiological aspects of the addiction and the withdrawal symptoms that occur as a result of stopping, which are very scary and sometimes dangerous, especially in alcohol. The emotional and triggering sides of it, the coping mechanism side. So they're really fighting a battle on three fronts, and it can be very difficult when you're not understanding that full picture.
Folks, hang out for a sec. We're going to go to a commercial. We'll be right back. We're going to talk more about the warning signs of alcohol abuse. You won't want to miss it. We'll be right back. Spring is a beautiful time in Detroit and Southeast Michigan. American Advantage Home Care brings that energy, joy, and vitality of the season right into your home, coupled with skilled home health care services. Our world-class team of clinicians can help you to thrive, maintain, and rebound in the comfort of your own home. Finding a home health care agency more compassionate and caring than American Advantage Home Care is a long shot. Welcome back to the Home Healthcare Today show. The topic is alcohol awareness. A quick shout out to our sponsor, Meridian Health Plan. Meridian is the sponsor of the Home Healthcare Today show. Care above all else. So prior to our commercial, we were talking with Jordana here about alcohol awareness and triggers and emotions, right? So emotions are usually triggered by events. All events aren't necessarily positive. We started the segment with some positive events, but we understand anniversaries of deaths, anniversaries of divorces, loss of any form tends to serve as a reminder, and that reminder sends some people into drinking or binge drinking to an extent. So, what are some self-tests that a person could, quote unquote, perform, Jordana, to ask themselves, hey, is everybody right about me? Am I really the loudest person in the party? Did I really say too much or do too much? Am I really a different person under the influence of alcohol? How can a person do a self-check?
There's a really easy way to do that. We call it the CAGE screen.
Okay.
And it's 4 simple questions that everybody can just ask themselves right now.
Yep.
First of all, has anybody asked you to cut down on your drinking, right?
Yeah.
Is anybody, friends or family, annoyed with you when you drink? Is that something you're seeing?
Yeah.
Do you ever feel guilty about your drinking or things that you've done when you were drinking?
Yeah.
And then the last one for E is an eye opener. Have you ever needed to wake up in the morning with a beer or a shot? Any answer, we say 2 or more, but especially with that eye opener, if that's kind of something that's happening, you really need to look at your habits.
True.
And really start talking to maybe your primary care doctor or your counselor about what some of those options would be for initiating some care.
Okay, got it. Now, with the self-assessment, I think, Jordana, we could spend a little more time on it.
Mm-hmm.
How can a person be more objectively fair,
Sure.
versus subjectively saying, well, me compared to alcoholic so-and-so, right? Or drink too much so-and-so. I'm not that bad, because I know people that do it all day long. At least I go to work, right? So how do we help people to kind of, be a little more accurate with their self-assessment?
Addiction is the greatest deceiver.
Yeah.
One of my patients described it as the devil in the mirror. So you have to really recognize that sometimes your internal talk might be the addiction talking, and our brains will trick us to do the things that we think will be best for us, right? So sometimes it really comes down to having that honest conversation with yourself or with somebody else about, internal self-awareness. In the recovery community, we always say, don't compare your journey to anybody else's. Your journey to sobriety is very, very different than the person that's sitting next to you. Absolutely. If your questions are triggering a problem for you, it's a problem for you.
Absolutely.
And I've seen people go to providers and tell them, I have a problem with alcohol. And even the provider has said, you're fine, I've seen worse than you. If the person identifies the problem with themselves, there is a problem with themselves, right?
Absolutely.
So recognize where that person is at.
Yes.
Hedging on the pandemic, we had a lady that came in because her daughter started meeting her at the front door with a beer. And she was like,
not a newspaper, not a pair of slippers, but a cold one.
Yes. And so for her, that was the wake-up call of, I need to put something in place here because my 3-year-old is recognizing this as a habit for me.
Ooh.
So,
that's real.
Realistic evaluations and asking yourself those 4 questions, or even asking it of a friend or a spouse or somebody that you really trust, can kind of start putting things in perspective. And then the first step in getting sober is in acceptance and awareness, right? So let's start moving towards that conversation.
Jordana, excellent advice for sure. Let's talk about Vivitrol. It comes up a lot in your work.
Yes.
You've called these injections the months of sobriety. Walk us through how it actually works for alcohol cravings, and who's a good candidate.
So Vivitrol is a once-a-month shot, goes in the butt. All right.
Got it.
What it is injectable naltrexone. So has anybody ever heard of Narcan? It's the same thing, but it's a shot that goes into the muscle, so it lasts for a month. Now, how it works is it actually works on the limbic system of the brain, the part of the brain that's kind of triggering you to want to drink. And what it does is it kind of puts a gate around those opiate receptors, that part in the brain that's triggering you to have those cravings. What's nice about that gate is nothing gets in and nothing gets out, which means it's slowing those thoughts to drink. But if you did drink, nothing gets in. No euphoria, no no buzz. You don't feel anything. You can just, you take a drink and you're like, oh, well, that didn't do anything. And you put it down and walk away. We call it the Sinclair method, but it's actually a very strong, like, I don't really need that kind of fit. So Vivitrol is a very good preventative for that.
I got it. Okay. So it blocks the intoxication or that feeling, that euphoria of, that was a shot that I really needed. Let me get another one to take the edge off. But that's not taking the edge off.
Blocks the effects. It won't block from a safety standpoint.
Got it.
If somebody is getting the Vivitrol shot for the wrong reason,
facts,
their parole officer, or my wife's going to kick me out of the house, whatever, and
they
they decide, I don't care what that girl says, I'm going to drink come, no matter what, and they just start dumping down that crown for whatever reason. Their blood alcohol level will still rise. They just don't know where they're at. They don't feel it. So it can be a dangerous situation. So you have to make sure that you are in the mindset of being sober in order for Vivitrol to be a safe alternative for you.
Okay.
All right.
So the windows, 14-day sobriety window for opiates.
For opiates, because it will react to an opiate and make them sick.
Okay.
But for alcohol, we can give it within 24 hours.
Got it.
So as long as you have not had a drink within 24 hours.
Okay.
So,
that's good to know. Okay, Jordana, you and your team travel to 40 site partners every week. Okay, that's like 6 a day, right? Or 7, right?
5 to 7, yep.
5 to 7, including shelters, recovery houses, parole offices, and churches. Why does meeting people where they are matter so much for alcohol more specifically, or alcohol recovery more specifically?
When people are struggling with addiction, you have to be able to respond when they're ready. If you are telling them, oh, I'm going to set you up with an appointment in 1 week, the consistency or the follow-through drops significantly, which means you have to be able to respond when they're ready. And most of the time, people are ready when they're actually clear-headed for the first time, right? Individuals that are more advanced in their addiction, struggling from homelessness, loss of jobs, loss of licenses, really struggle with kind of that transportation and all of the other socioeconomical barriers that kind of come with it. So we have to make it easy. Human nature means that we are going to do things that fall in line for us, right? If it's too hard, if we have to jump through too many hoops, we're not going to do it. And that has nothing to do with addiction. That is just human behavior. If you have to go to 3 different doctor's offices to get this done,
never mind.
It's not going to happen. If the RV is at the homeless shelter and we're able to do your blood work and we're able to give you the shot and we can get your blood pressure managed all at one spot, we have a much better chance at getting those patients stable and ready. And then when their head is clear, then we can help transition them into a traditional primary care for more consistent care. But we're the response on the ground, right where they need it.
I get it. I totally get it. Jordana, let's talk a little bit about insurance. You know, a meeting like you and I were hanging out in the field, the community, at a Meridian Health Plan member summit. And some plans get it, some don't. We were right there in Chelsea, Michigan, which is what? Home of Jiffy Mix, right? Yeah, so we were there, right? Now, when it comes to plans and reimbursements and coding when you submit claims, and a lot of times claims could have like multiple diagnosis codes, the CPT codes, and the like. And then some plans look at it and say, I got to down code some of this. Are you really checking on all these things? The chief complaint was just this versus that. All right. How can we help some of our partners out there to understand the complexity and the nuances of mobile delivery of service and then the multiple things that we're able to address out there in the field?
Just mobile clinics, because of where we are going. We are operating a little bit differently than a traditional primary care doc. You go into your doc or you go into your eye doctor and you say, doc, I have a headache, I can't see. But you're dealing with patients that have a little bit more of a consistency basis. When you have someone that walks into an RV parked on the side of the road outside of the homeless shelter that hasn't seen a doctor in 6 months or longer, you're not only dealing with their addiction and their hypertension and their uncontrolled diabetes and their anxiety and their depression, but you're wondering if you're ever going to see this person again, right? Am I going to be able to get them stable enough to stay in the shelter, or are they going to walk, right? So we do have to try to address as many as many things as we can while we have them there.
There you go.
Because hopefully, even if they walk the first time, what we're hoping is that they'll recognize the van the second time.
Amen.
And so maybe in another month, they'll see one of my clinics, maybe even in a different, they saw me in Detroit, but maybe they'll see me in Flint and say, oh my gosh, that's that van. I saw that one time. And they know they can walk in and get that same level of
Yes,
care.
absolutely.
So it really does look at that holistic approach. And what we're trying to do is keep that patient as stable as possible
Yeah.
so that consistency and hopefully that buy-in for healthcare comes back. What the mobile clinics are really trying to do too is really try to reestablish confidence in healthcare,
Trust.
which means we have to be approachable. We have to be uber friendly. We have to be accepting.
Yes.
So it is a very different mindset as opposed to say, well, your time's up. It's 15 minutes. We talked about one thing. We'll see you next week.
Yep.
We have to be the ones that are willing to sit down and listen to the stories and really take in the full patient that's sitting in front of us.
Absolutely.
In order to get them to trust us so we can get them into those higher levels of care afterwards.
Wonderful, Jordan. I love it. All right. Real resources for folks. If someone's at home struggling, knowing that they have an issue or a problem, or a loved one saying, hey, this is the best episode ever. You should have been paying attention to this. What are some steps that we could give to some folks to get some help today?
Well, you can always call the Recovery Mobile Clinic.
Yeah.
We have our website, recoverymobileclinic.com, and our phone number is 248-567-2334. But talk to your primary care doctor. Talk to your counselors.
Yes.
411 is another call that you can call. It's a suicide or I need help hotline.
Yes.
There are a lot of resources out there to get support, and our case managers will help walk you through it. Even if we can't help you directly, we will find some support for you.
Jordana, congratulations. I love what you've built.
Thank you.
How can folks out there help you in your mission to be able to help more people?
A simple way to do it is follow us on LinkedIn, Facebook, socials. That doesn't cost anything to like and share a post. Absolutely. But the word gets out there. But we are a nonprofit. We take donations. We never turn anybody away for not having insurance. So if you donate $100, it goes into what we call our patient recovery fund. Yeah. So your money pays for a patient visit. It does not pay for my salary. It will not put gas in the RV. It just pays for a patient visit. So there's lots of ways to contribute. But we also take donations that we disseminate to the shelters. So if you go on our Amazon wish list, there's bottles of water, adult diapers, wound care supplies, anything that you can send to the clinic will get out into the community and help those clients.
That's awesomely amazing. Jordana, thank you for providing so much insight to listeners and viewers. All right, folks, that wraps it up for this episode of the Home Healthcare Today show. We will catch you next Saturday at 10 a.m. Be well and take good care.